Hello, everyone. I hope you guys are all staying safe and staying healthy, especially during this historic time in our world's history. Part 3 of this coronavirus series is basically just a follow-up on everything that we know about COVID-19 and just seeing if there are new developments on this disease and if there are any new treatments on how to combat the virus itself. I also want to thank you, all of my followers, for asking informative questions about coronavirus, asking good questions about this disease and whether or not you guys have symptoms. I've received questions from all over the world, and I hope that everybody that has asked questions about their personal symptoms are doing well, that they've sought treatment if they've had to seek treatment, and that they're staying healthy, especially in this time in world history. If you guys have questions for Dr. Gathe or something you want to hear in the next episode, be sure to link those questions in the comments below, and I'll be sure to ask Dr. Gathe in part 4. And without further ado, let's go ahead and get into part 3 of the coronavirus conversation. We're back with Dr. Joseph C. Gathe Jr. Uncle Joe, once again, thank you so much for all that you've been doing these past couple months with coronavirus.
Thank you so much. Keep the prayers and blessings going for all of us fighting the epidemic, and I'm happy to be back with you.
Okay, so in the last episode, we talked about how you opened up 45 beds dedicated entirely to coronavirus patients. What have you seen within the past week?
Well, we're still in the growing phase of our unit. We've got everything set up and we're ready. We have not seen the surge happening in Houston yet, like you're seeing in New York and New Orleans and maybe Detroit. And so we're just bracing for what is to come. And unfortunately, we really don't have any idea of what to necessarily expect over the next couple of weeks, but we are becoming about as prepared as we can be for this unknown surge that will be coming.
Can you talk about the preparations that you guys are taking, or is that confidential?
No, not confidential at all. It's, every hospital is doing what they feel is necessary to do. My primary hospital didn't really want to set up a unit, so we had to go to another hospital. And with the help of Congresswoman Sheila Jackson Lee, we're able to essentially outfit an entire wing of a hospital dedicated simply to the COVID-19 patients in the epidemic. It allows us to safely enter and exit the location. We can even take a shower and things on the way out. We have dedicated scrubs and PPEs there available for us. The question is always whether or not we have enough. And unfortunately, we don't know if we have enough because we don't know how many people are coming, but we're sort of geared for as many as we can get. We were working on some conservation mechanisms so we can have minimum in and out of the unit and therefore hopefully be able to save some of the PPEs. We have ventilators available. Do we have enough? I have no idea until we see how many people will come. Our goal is to hopefully be able to get people into the facility early enough and perhaps begin some of the treatments that may work to try to keep people off the ventilators if at all possible. But, I tell people sort of like gearing for a hurricane, you hope you have enough lanterns and candles and batteries, but we don't know if it's a category 1 or a category 5. We just have to brace and be ready when it hits to be able to ride the storm.
We've seen that 113 cases have seen full recoveries from coronavirus. What do you believe has been the biggest factor in terms of recovery?
Well, the answer to that question is I don't know, because there are many people that have no symptoms at all ever and never get sick, versus some people that get mildly sick, versus some people that get moderately sick, versus some people that get very ill. Now, the obvious ones are people that have other issues going on, their age, heart disease, and hypertension. But I can tell you the first 10 cases that I have seen at our unit, all of them below the age of 50, and less than 50% of them have had some other problem other than COVID-19. And so this whole issue is about who's going to do well and who's not, who needs treatment and who doesn't. Unfortunately, it's going to be a big learning curve for us because we really don't understand exactly what you're asking. And so it's going to be a learning experience. I've learned for the first 10 patients sort of what the disease looks like, and it's not necessarily looking like what read in some of the articles. One of my patients presented simply with nausea, vomiting, and diarrhea 10 days before he ended up with the disease process. One gentleman presented, I thought he had appendicitis, he had so much belly pain, and his original COVID nasal screen was negative, even though he looked like he had the disease, and it took 3 or 4 days for the test to turn positive. And so I say that to say it's going to have to be a judgment call on physicians about what to do with patients, who needs to be treated, who's not, who needs to come into the hospital, who doesn't, in order to be able to figure out where the what the details of the natural history, for want of a better word, of the process is, because it's very, very variable. It is not straightforward.
So Houston Methodist Hospital is the first to use plasma in terms of their research of COVID-19. Do you know anything about that?
So one of the ideas of treatment is to take antibodies from people that recovered from the infection and give those antibodies back to someone that is not recovered in hopes that that will help the person's immune system to tolerate the virus or to get over the virus in a more timely fashion. I don't know exactly what's happened to those 2 patients, but it is one approach. The good news is on paper it should work. The bad news is it's going to be impossible to scale that treatment up in a large number. Let's say it does work, but to get antibodies from a person, process them, get them through the blood bank, and get them back to a patient when we're dealing with perhaps hundreds of people that may come in on a daily basis, it's unfortunately not practical, but we need every approach to do it. Maybe some people get that, some people get other things. But unfortunately, we just don't have a good idea what works and what doesn't. And so we're sort of, how should I say, we're not making it up as we go along, but we're trying to design what makes sense from what we saw in China and what we saw in Italy, and what doesn't make sense, and try to tailor the treatments to the individual patients that are coming to see us.
What is that like for you? Because I know, we talk about the medical aspect of things, but what has it been like mentally trying to solve a Rubik's Cube, if you will, with coronavirus?
Well, interesting enough, it's not that much different than trying to solve the HIV crisis that we had when we didn't have any treatments, we didn't have any tests, we didn't really know what we were doing. The difference is we had longer periods of time to think through this because we knew how to prevent people from getting the disease early on. With this particular epidemic, we're having to make decisions in a matter of days instead of a matter of weeks or months. And so when we would like to do studies, we don't have time to do studies that are going to be relevant to the people coming in to the hospital. So what it does is it taxes every neuron that I have. It taxes the over 30 years of experience I've had about what looks like it works or what doesn't. It makes us in between patients actually go and read what the latest literature is, what works, maybe small studies that say, hey, I tried this and worked, or it worked, or hey, I tried that and it didn't work, and try to come up with a cocktail, if you will, of things that make enough sense that we can put them together to safely give to patients. And the other thing is that we may have the cocktail to put together, but if the medicines are not available, we can't put that together. So some of the drugs that are being studied, there's a drug called remdesivir from Gilead Pharmaceuticals. It's going into studies, but it is not scaled up in a fashion that we could give them to patients readily because they haven't been on the market. Drugs such as hydroxychloroquine that are getting a lot of press, for want of a better word, is potentially more available because it is, at pharmacies and things. And so sometimes what we try to craft together is simply what we actually have on hand that we can put together that makes sense. And so it's a learning curve, it's a learning experience. The benefit of the unit we have is we can do it in an organized fashion. So if something looks like it works in 10 or 20 people, we can get that information out there very quickly and say, hey, we tried this in this group of people and we've had this success or this failure or this toxicity, so other physicians can sort of join in and say, hey, we're going to try this too and let you know what happens. And so it's a trying time for us, but it's one in which we've got to put all the things that we've learned in the past to try to put them together quickly to try to get these people that are sick or these patients that are sick into treatments quickly and try to keep them off the ventilator and get them out of the hospital.
So you were on an AM radio station in Houston the other day, and you had mentioned that Z-Pak has been one of the medicines that has come up in potentially treating coronavirus. And you just talked about how there's a cocktail of medicines that you guys are trying in terms of coronavirus. Has anything worked so far with your patients? Are you seeing things that, you know, could potentially be a source of treatment for current coronavirus patients?
So one of the protocols we have at our institution is to use a combination of zithromycin, which is a Z-Pak, and hydroxychloroquine, which is the anti-malarial, anti-arthritis drug called Plaquenil, in conjunction to see if it helps people. The way that combination theoretically works is hydroxychloroquine has direct antiviral activity, and the Zithromax, it's an antibiotic. It really doesn't work on the virus, but it works on the immune system to try to smooth out the immune system, if you will, so it doesn't overreact to the virus. And that's how this cocktail was put together. What we've seen in the 7 people that we've treated, including people that are very sick, not on the ventilator, but very sick, is all 7 of them have gotten better. Now, does that mean this is the cocktail for everyone? The answer is no. Would they have gotten better on their own without the cocktail? The answer is I don't know, because we treated everyone. A good study would be to treat half the people and don't treat the other half. But in a situation where you see people dying, we don't have the option of doing what we call a placebo study. And so what I've seen with this cocktail is that it works if you give it early enough in the illness. If they get to the point where they need a ventilator, I'm not exactly sure this cocktail would be the one to use. But if you treat early when they're just having fever or mild symptoms, we think it may be one of the ways to mitigate the damage that the virus is doing in the patient and to get them well and out of the hospital more quickly. It does have toxicity, so it needs to be monitored by physicians that know about the drugs and can monitor, if it ends up with, end up with problems. It could slow your heart and other things. So it can't just be done and not monitored. And that's really what one of our big protocols we're doing. But we're still looking at other things. Things are coming up on almost a daily basis that look promising. And when we have an organized unit in our community like this, we can actually go out and try to get some of these things in an organized fashion. We're looking forward to doing that in the next few weeks as necessary.
I know in part 1, we talked about Tom Hanks and his wife in Australia and how we didn't know if coronavirus was a seasonal disease. Being that we're a few weeks removed from that, is there any sign as to whether or not coronavirus will be a seasonal disease?
Well, it's still hard to tell because, we're not into the spring and the summer. The hope would be that would be so. But unfortunately, there are so many people that are potentially infected here in Houston anyway. It's too late for the seasonal changes to do anything. We're going to have so many people we're going to have to deal with now. It's not going to affect what we have to deal with at this juncture. However, the hope would be after we get through this surge, on the back end, if the virus tends to not be as contagious, for want of a better word, in the summer months, that would be fantastic. But the concern that the other community has, the scientific community, is that when the fall and the winter comes back, there is concern there's going to be another bump in COVID-19 at that time. The hope would be we would be much better prepared to deal with it with medicines that look like they work, even with hopefully a vaccine, but a much better understanding of what looks like we need to do as far as treatments are concerned. But that's going to be a long way off. So I say that to say I wouldn't count on us being coming into a warmer climate to not continue to do the things that it takes to mitigate the spread, which is washing your hands and the social distancing that we have talked about so many times, both in this podcast as well as you're seeing on the television, because it clearly makes a difference.
Dr. Rishi Desai was recently on Fox News, and he was saying that with coronavirus patients, those who are able to recover from it and survive it have built up an immunity against the disease. Do you believe that's true?
I think that it theoretically should be true. We don't know that for sure until, we follow the patients along that have recovered, but the robustness of the immune response should be one that's theoretically enough to not get COVID-19 again. Would I put myself out there if I was recovering and had antibodies without doing personal protective equipment and things? The answer is no. But the thought and the hope is, as with other coronavirus infections, if you recover with a sufficient antibody response, that you should not get this particular virus again.
You've said previously that we may not have a vaccine in time for this particular version of the virus, but we would have it in time for COVID-20 or COVID-21. Why is it that viruses evolve over time? And I know with the flu vaccine, each year the flu vaccine looks different from the one last year. Why is it that viruses evolve over time and we're constantly playing this cat and mouse game of trying to find a vaccine for a different strand of something we've already seen?
So that's a good question. So not all viruses evolve. As you know, as a kid, you get measles, mumps, and rubella vaccine. And for the most part, you don't have to do that for the rest of your life because measles, mumps, and rubella don't change. But when you have infections we call zoonosis, and zoonosis is a virus that primarily is in animals, but can come out seasonally to affect humans. The classic zoonosis is influenza. It comes this time of year and you get a vaccine or you get over it, but it comes back different next year that you have to have a different vaccine. It's because it can recombine in the animal kingdom and come out differently. That's why we have the avian flu, where the flu interacted with birds, or the swine flu, where it interacted with pigs from Mexico. And so those are zoonoses. Coronavirus infections are also zoonoses. It's primarily a disease or an infection of other mammals. The ones that are important to us are bats. Bats have coronavirus infections, or they carry coronavirus virus routinely. Other animals also do it, but they tend not to affect humans unless they combine and change their DNA. I read an article that was very interesting. They talked about, we all have DNA, animals, viruses, and everything else. It took 8 million years for human DNA to change 1%. It takes 8 days for coronavirus RNA to change 1%. So just that quickly, it can change just like that. And that's exactly what happened in China. It combined with another animal. The question is, which one was it? There's a question of whether it's a snake or whatever else. At this point in time, for us trying to treat, it doesn't make this what it combined with, but it combined with another virus, and it became very contagious and potentially lethal to humans. So that's why it keeps coming back. And the moral of the story of that is, if you take a COVID-19 vaccine, it's not going to protect you from COVID-20, COVID-21, and COVID-22 that can change and come back in a different year. But the hope would be the scientific community, just like they try to get on top of the flu vaccine every year, they can get on top of what looks like the coronavirus infections that may be coming up. But that gets in to also that we have to prepare. And one of the concerns I have is the United States government has sought fit to stop programs that try to predict these things. There's a program called PREDICT that was organized back when these epidemics were first being seen, like SARS and MERS, to try to predict which viruses may be coming out. And the current administration has felt that this was not a cost-effective thing to do and completely shut down the PREDICT program. So we don't have the ability, at least with that group, to be able to predict when the next coronavirus infection can come. And so I say all that to say, what I've said on all the podcasts I've done, in order to deal with this epidemic, in order to deal with the future epidemics, it's going to take a societal response. I can't fix it. Dr. Fauci can't fix it. The society has to say, we're not going to let this happen again. We want to have the people out there on the front lines to help us predict. We want to have somewhere in storage the things we need in case there is another pandemic. If you're sitting around in Houston where you're worried about hurricanes, you don't wait till the hurricane is over your head to go out and get a battery. You have a closet that has batteries and lanterns, and you say, okay, one's coming. Let's open up our emergency package, and everything flows. We need that in the United States. We need an emergency set of ventilators. We need an emergency set of PPEs. We need an emergency set of gowns and gloves. We need an emergency set of healthcare providers. There's not enough of us out here to fight the infection. We're asking people that are retired to come out. We're asking this part of the Army to come out and this part. It's not an organized response. And what we need to do when we see this coming is maybe to push the button and everybody goes to their battle stations and we have our equipment to fight the war. And I can't do that. Society has to demand a better response on a federal level, that we have an organized response. So when COVID 20, 21, or whatever else has come out in the future, we're not reacting to what's happening. We're going to be proactive and know exactly what we need to do to hopefully prevent it from coming, but most certainly to know how to battle it if it comes to our shores, despite our predictions.
I believe organization is key, especially on a national level. I think that would definitely rally people together on the severity of the situation and encourage more people to take the safety precautions that our government leaders are advising us to do. So in terms of viruses, I know we've talked heavily about HIV. I'm also very familiar with your work about hepatitis C and West Nile virus and things like that. Why is it so hard to find a cure for a virus? I know on Saturday you mentioned that the only cure to a virus that we really have available is hepatitis C, where we see bacterial infections are a lot easier to cure than viruses. Why is it so hard to find a cure for a virus?
It's a good question. So bacterial infections are less complex and they have more targets where we can actually take medicines and kill. For example, certain bacteria have cell walls, a wall around them that protects them. You can take penicillin, poke a hole in the wall, and the bacteria completely dies. A virus, you poke a hole in the wall, and it can figure out how to continue to live because its RNA, its genetic mechanisms change so quickly to survive. And that's why it's so difficult to try to get a medicine that hits a target that's continuing to change. It's just like you had a gun, but you hit one target, but the target turns into something else. You got to hit that one. The target turns into something else. You got to hit that one. And it's just very difficult to be able to hit those targets with one drug. I find it absolutely fascinating that we're even able to find the hepatitis C treatment and cure. I never thought in my lifetime I would see any medicine that would cure any viral illness, especially that one. And to get something like that to come up is, one, amazing, but two, it actually says that it can be done. And the hope is that the researchers that are far smarter than me in the laboratory can say, okay, it's not the exact same thing, but the principles may be the same in order to be able to get a medicine that will kill the virus. And so we have a stepping stone, if you will, to take from there, and hopefully science will be able to come forward with it. But again, society has to invest in that research. Right now, there's not a lot of research for infectious diseases. We have bacterial infections I can't treat because we don't have any antibiotics. Nobody's doing research because nobody can make money on antibiotics for people that have infections. The research is going into obesity drugs and cancer drugs, et cetera. And we need all of those, but you can't do those at the exclusion of the research we need for infectious diseases. And again, I hope that society recognizes that and says we need to prioritize companies that are looking at antivirals on a broad scale in order to be able to deal with this, unfortunately not this epidemic, but the ones that clearly are going to happen in the future.
So moving on to a more societal point, I know the CDC has recommended that everybody start wearing masks in public. And we've seen the difference between a regular mask versus an N95 masks and how they are, unfortunately, in low supply. What kind of masks would you recommend to society? And should we be wearing them all the time when we're out and about in public?
It's a very good question because you get mixed messages, and one day they tell you not to, the next day they tell you to. And so unfortunately, we're not getting a consistent message from our leaders, and it makes it difficult for me to lead and guide our community about what to do. The whole issue of wearing a mask out in public is the following. It is not the mask to protect you from someone else. It's the mask to protect you giving the virus to someone else. So it is making the assumption that you actually are positive and we don't want you to cough on someone else. But the mask to protect you from getting it from someone else coughing is not likely for what they're asking. So the goal of the CDC is for those that don't socially distance, for those that don't wash their hands, for those that go out sick and potentially infect people, we want to make sure that they don't spread the virus. And so they ask people to wear a mask potentially because you can be an asymptomatic carrier or passer of the virus. Now, that doesn't take an N95 mask if you decide to do that. And the problem with this whole thing is, I don't know if you worn a mask, but when you put a mask on and you're not used to wearing a mask, it's somewhat uncomfortable. So what ends up happening when you put it on, you start putting your hands on your face and you're moving the mask around and your glasses fog off and you take the glasses off and you wipe your head. You've just defeated the whole purpose of why you put the mask on and put yourself now in jeopardy if your hands aren't clean because you're putting them all over your face. And so, and we're not as a society used to wearing masks like some societies are. You go to some of the Asian countries and wearing a mask is part of the culture. So they're used to doing it. They have fly masks and all kinds of masks, designer masks, everybody's part of their wardrobe. We're not used to doing it. So I see people walking through the store with a mask on and their hands touching the grapes, touching the cart, and then moving their mask around. You can't do that. And so it's better that you don't have the mask on. So my recommendations when you hear these things is common sense. If you're in your car and you're the only one in there, you don't need to wear a mask. If you're at the gas station filling up your car and there's nobody at the gas station but you don't need a mask. But if you go into the grocery store and there are people around and you're standing next to the brave cashier that's having everybody in her face or his face all day, maybe you wear the mask as not necessarily protection for you, but protection for the people around. And put it on for that period of time. You get out to the car, you can take it off because you're there on your own. So use a common sense approach. But I think it'd be nice until we get over the hard part of this epidemic, for want of a better word, to do that over the next few weeks if you have to end up interacting with the public.
That's really good to know. And that's a good point to make. I know I've seen in college, like there were quite a few students that would wear masks just on an everyday basis. And I know that it's a lot to get used to just having something extra on top of your face. So from a sports standpoint, I know we've talked in private about the NFL, the MLB, even the NBA playoffs. Do you think that they'll come back at some point this summer or late summer, early fall?
Well, what I can tell you is when we get to the backside of this epidemic, whenever it is, society is going to be different. How we interact and what we do is going to be very different. And I just don't see anytime soon large gatherings of several thousand people for things that they don't have to necessarily be at, which is very disappointing because all of us like our sports. It's our downtime. It's a time that we can just relax our brains and cheer and throw things at the TV when they trade the Hopkins away from the Texans. That's a whole nother discussion item we can have. But I think it's going to be different. And exactly what it's going to look like, I don't know. I don't see the baseball season starting anytime soon with audiences of large numbers of people. I don't see the NBA playoffs really happening because by the time they get started, it's going to be time for next season. And who knows what's going to happen with the NFL team. So I really don't know what's going to happen on the other side, except it's not going to be business as usual anytime soon. Definitely within the next few months and maybe not till sometime in the fall. But as I said, in the fall, we may have another COVID-19 little outbreak. That's what we're expecting. And so it may be that these things are going to be a lot different. It's sort of difficult, I guess, to watch a game with nobody in the stadium and you're watching on a live stream. But again, that's putting the players at risk if they're not already positive. So it's going to be very different. And I think, quite frankly, nobody really knows what it's going to look like.
Yeah, and I agree with you on that. Just from a sports standpoint, working in the industry, working for clientele that broadcast the NBA, there's so much that's up in the air, and every day we learn something new. So a lot of us are still unsure as to whether or not the NBA season will come back. I mean, we hope that sports will come back this season. We hope that it'll come back sooner rather than later, but there's still so much unknown out there. And that just adds to the uniqueness of the situation. I don't know if there's ever been a time, maybe 100 years ago, but even then, like, the landscape of the world was so different with World War II and just the spreading of technology through radio. But I don't think there's ever been another time in world history where the entire world has been put on pause as a result of this coronavirus.
And I just want to add in, it affects a lot of people. It's not just me watching the games on TV. It's the people selling popcorn and tickets and ushers, and you. I mean, a lot of people just spend on sports for society and their jobs, and that's a huge group of people that don't have ready jobs to come back to necessarily when all this goes. And so it's not just being able to watch it. It's the whole segment of society that depends on the sports industry for their livelihood. And so there's a lot of reason to try to get it back. We just have to figure out how to get it back where everybody's safe, and we're working on that.
And I think that's the key thing, is safety. Like, there's so many people, like, for me, I work in post-production, or, production crews, or the freelancers that are actually at the games night in, night out. I know there would have been plenty of people here tomorrow for the national championship for men's basketball that were, look, this was going to be like their marquee, moneymaker of the year. So, there are a lot of jobs that have been impacted by this coronavirus. A lot of things that, the regular American common person wouldn't necessarily think about. And I think that's, again, like, the uniqueness of this situation. Like, everybody has been put on pause. Well, Dr. Gathe, those are all my questions for this week. Thank you so much. I know you have to run to the hospital tonight. So once again, thank you, and all the healthcare workers who are out here fighting this virus and, putting your life at risk for the good of us all.
And a shout out to, it's not just me. It's we talked a little bit earlier. It's the grocery store people. It's the bus drivers. It's the firemen and the policemen that are going to people's houses not knowing what they're going to see. It's the nurses that are at the bedside of patients 12 hours a day. It's the person that cleans the people's rooms. It's the respiratory therapist. There are a lot of people that are sacrificing for our communities. And I like to give a shout out for them. And I like to say that the social distancing and things that you're doing out there are helping them to live, because we don't want them to get the infections. We're seeing healthcare professionals, unfortunately, come down with this. There are over 60 doctors in Italy caring for coronavirus patients that have died. So the less people we have to take care of, the better shape we're going to be as far as putting ourselves at risk and our families. So shout out to all of those people that are really on the front lines, and got a lot of good people fighting and helping, and we need everybody in our communities to stand by us, and let's get this taken care of.
I couldn't agree more. Thank you to all the healthcare workers, grocery store people, janitors, everybody that's on the front lines still weeks later after all these lockdowns worldwide. Thank you all so much.
Thank you.
For more on coronavirus and infectious disease medicine, please visit the links below. Stay safe, everyone.